and welcome to Free Speech with CR. I'm Molly Blakemore, your host, and I'm joined with my co-host, Dr. Keith Flamer.
Molly, it's great to be here with you. And our guest today is Michael Keleman, and he's the CEO of Providence and Redwood Memorial Hospitals.
St. Joseph.
St. Joseph.
Yeah.
Okay.
We just call it Providence Humboldt.
Oh, I like it. Okay. That makes it so much simpler.
I'm trying to just make it, we're one system. Yeah.
And
It's a
St.
great thing.
Joe's, do we still call it St. Joe's? Or?
Yeah, there's still two separate hospitals, separate licenses. But when I talk about it publicly,
It's just
we are Providence Humboldt because it's the hospitals, there's a medical group. And I think at the end of the day, if you're living in this community, it's just Providence. You don't really care.
Here's a question for you. There's a lot of conversation about rural healthcare and what the answers are to the solving all the problems of the world in rural healthcare. So help us understand what the real problems are and what the answers from your perspective are.
Well, let's solve it today, Keith.
Yeah, because you know what? Everyone has an opinion. I'd like to know your opinion as the frontline CEO.
So problems and solutions.
Problems and solutions
Okay.
from your perspective.
I'm also going to say I think there's probably different variations of rural healthcare. I think that's also important to kind of share.
Talk about that some more for us.
Yeah, so there's rural healthcare where if you talk to some people, well, actually recently we had our St. Joseph Gala, right? And at that gala,
Which I had a very good time in, by the way.
thank you.
It was fun.
Well, the Moras came up and they did the big auction. And one of them mentioned that they have friends in other rural communities that drive 4 hours just to get to the nearest emergency department.
Yeah.
So that's one version of rural healthcare. Our rural healthcare, I think, is just defined by our population density. Massive county, about 130-ish thousand people, give or take, spread across the county. So we're rural. I'd say the biggest challenges with rural medicine, there's a few things. One, I'm trying to bucket these. So one is physician in terms of access. It's not that we lack subspecialty care. It's the number of subspecialists we have, and that has to do with population density. I think two, rural environments, how do they attract people? I don't think everyone understands what it is to live here. I don't think everyone understands that you still have a lot of modern amenities, but it's a balance where, for example, if you go to Los Angeles or the Bay Area, you don't ask yourself, gosh, I wonder if they have good schools for my kids. You feel confident you'll find a good school for your kid, even though you have no idea what the schools are. When you move to a rural community, that's a very legitimate question because you don't actually know how many other schools and options they have.
Sure.
I think the other part of it is just funding. Rural communities are interesting. When you go into metro areas, actually per Medicare, rural communities get paid less. So a physician working in a rural environment who is billing for Medicare is actually getting paid less than they are in a metro area. And I have to remind myself of why that was, because I remember being confused and inquiring about it. And I think it had to do with the fact that they looked at it as the difficulty. And I think it was seen that, well, it's probably more difficult. You have more patients. There's more demand in a metro area than rural.
Could it be cost of living also?
It could be, but I think it had more to do with that.
Okay.
I have to remind myself, so don't fact check me on this one, or please do.
Or someone will, but go ahead.
Yeah. But the real challenge is in a rural environment, what I'm learning is the pathology here, meaning how sick people are. And I don't think we factor that in. And that's a challenge for a physician here. A physician comes into this environment and you see people that are just very, very sick because they don't access care the same way people would do in like the Bay Area. I think people here are very resilient.
Mm-hmm. Never thought of that.
Solution to it?
Yep.
I would argue the best solution we have is our community. And it's the catch-22 of the beauty and the challenge of a rural community. So Humboldt right now, for example, it's a beautiful community. It has a lot to offer. But how do others know that? If I bring in, let's say, a new physician and they come in and they're going to go, okay, and I put them in a hotel. What hotel did I put them in? And I mean that I genuinely. Ask yourself that, or people who are listening to this right now, where are our hotels located? If you had a family or a friend and you just moved to Humboldt and you wanted them to experience your new home, is that where you would want to house them in that hotel? That is not a good reflection of who we are, right? I think the second part of trying to solve this is how you help them feel that they're going to be successful and able to grow. I think anyone who comes out of, let's say, a graduate program or anything, when you're young especially, you want to make an impact, right? That's your motivation, is that you want to make a difference, okay? So when you come to this community, how do I give you a sense that there is opportunity to do a lot here versus small town, not a lot of growth? How busy am I going to be? How much am I going to be able to do here?
Yeah, we have a lot of the similar problems with recruiting people, finding housing, suitable housing.
Yeah.
Healthcare is a big one for them.
Yeah.
Schools, all of that. So we have a lot of the same problems with recruiting people. And I definitely hear your point about like where are they staying and what are they doing, especially young people. And is that another reason that we probably get? I know when I first got my doctor here, she retired within a few years. And so I think people maybe retire here, but they don't want to start their careers here, right? Because of what you've mentioned about opportunity. So that is
Yeah.
a challenge.
We're changing it though. Don't get me wrong. We're bringing on new physicians. So like we have a new interventional pulmonologist. We have a new general surgeon who started. We have another one starting in the fall. We brought on about 25 physicians in the last year. So we are growing access, but it's hard. It's slow. And
Costs money.
Yeah, it costs money, but even outside of that, I think the hardest part, it's not even always the physician. A lot of times it's the family, the partner, and it's not even them successfully living in the community. A lot of times it has to do with their family and how isolated we are. So, I family live in the Bay Area. How close are you? Oh, pretty close. Well, I also have an opportunity in Sonoma. Easier, yeah. And so that's sometimes the hard part.
You and I are part of these conversations about rural healthcare, and how do we find an answer to those? I find that everyone I talk to has a different idea about what the problem actually is. So what's the problem in your mind that our community should focus on to solve? Because everyone has a different interest, and they're eager to tell us what the problems from their perspectives are. What are those problems? And from your perspective, as a CEO of a major healthcare hospital?
The first thought that comes to my mind is care coordination, to be honest with you. I
Would you
could
talk to us
to
about
you,
that? What does that mean?
Yeah, and before I jump into it, I could talk all day about recruitment. I could talk all day about what we as a community can do. And like I know we've talked about home in Humboldt, there's a lot of things. But if you really ask yourself, what are people struggling with?
Yeah.
It's coordination of care. So what does that mean? Step one, how do you get established with the primary care? Find one. I know right now, just in Providence Medical Group, I have the capacity for about another 5,000 unique patients. That means that if there's 5,000 people in this community who are not established with the primary care, I have capacity. Now, if you all call today, it'll take you about 90 days before you get your first appointment, before you get established. It's a process. So one part of it is an education, and the community needs to know how to lean into that and get established. But again, finding it. I'm the CEO here of these hospitals, and I can tell you right now, it's not easy. The next part of care coordination is, let's say you have your primary care. Let's say you go to the ER, whatever it is, and they say, you need to see a cardiologist. You need to see a neurologist. You're now going to your specialists, right? What happens is you're leaving your primary care office, and they say, you need it. I'm going to put in an order. Here's your referral. Call this number.
Okay.
We've immediately, that right there is the whoopsie.
Yep.
We've given the burden, for lack of better words,
Back to the
to
patient.
you. So the problem with that is, one, you are now falling back into this phone system. You're on hold. You're waiting for someone to call you back. That's one of the problems. The other problem is in rural communities especially, everyone has different means. It's a different kind of demographic range here. And not everybody may have the time to sit on that phone, to make that appointment, or the flexibility in their work to get in when you finally say you have an appointment available. How do we ease that way? How do we ease that way that if you're in a primary care office and they go, you need to go see a cardiologist, I would love for us to be in a position to go, we're going to get you scheduled right now. What's a good day that time that works for you? That's what we're trying to get to. We're piloting that right now actually in partnership with Open Door in the hospital. So if you're getting discharged right now from St. Joseph and you are established with an Open Door primary care physician, before you're fully discharged, we have someone who's dedicated to scheduling your appointment with your primary care before you leave. And lo and behold, 96% of those patients are showing up to the visit because it's done for you,
Yeah.
right?
And when you give the burden back to them, also if they've had prior bad experiences, they're less likely to follow up, regardless of their level of need for care. I had that experience with the imaging center for my mammograms. They were really on me to make an appointment, and that's really why I did it. So I think that is even I, have the time and don't have bad experiences, and I probably would have let it go for a long time had they not been calling me. So I appreciate that, and I think that's.
But that's the coordination again, right? So there is someone
exactly.
looking out for you
Right.
and pushing you to go, hey, you gotta make sure you're doing this. And I think a lot of people get lost in that. And so a lot of times when I hear people to go, oh, we have no specialists, or it's taking me 6 months to get in. And like, for example, I recently had someone reach out to me because they needed to get in for a diagnostic scan. I won't give too many details, but it was a diagnostic situation. And they're like, yeah, I can't get in for over a month. And I was like, for over a month? That seems like an urgent situation. Well, we got him in within 2 days. There's always the space for it, but it's the coordination of care.
Not everyone can call you.
Well, it's also when our team looked into it, the way the referral was put in, it didn't have the right signals to say that this is an emergent situation. This person needs help and care coordination. It was just put in as an order. And that's a miss. And those are the opportunities for us as a health system. It's not a failure on the referring provider. It's not a failure on the patient. It's a failure on us as an organization, as a system to go, hey, how do we fix this? How do we ease the way of everyone that we're caring for?
And we have a new program coming up, Healthcare Navigator. And is that similar to what you're talking about?
That's huge. So that's actually something. This is the other thing that's interesting. I don't know if people realize this in California. California is one of a few states. It's like California, Iowa, Texas. There's a few more that escape me that don't allow what's called corporate medicine. So our physician network out here, so if you go into like Providence Primary Care, that's actually not employed by the hospital. We don't employ them. We have a very close relationship, but we do not directly employ physicians, okay? So one of the things we're talking about with our medical group partners is how do we...
Who does employ them? Are they independent?
They are actually their own. They are their own medical foundation, and then they lean into Providence for like back office services. So there's an administrative function that we Providence provide.
And they rent the spaces from you if I go to...
No, so they have their own board. Physicians here have their own board. They have their own leadership team. They have their own tax ID and everything, and then they contract with Providence Medical Group to provide them all the infrastructure. So like the salaries, the pay, the offices, the staff, we just pay for it all.
Okay.
Now the hospital does do, at the end of every month, we do a transition of funds to this medical group to go, okay, let's, help cover all of the expenses associated with it. But we don't actually directly employ the doctor. They're their own self-governing body, and that gives them the autonomy to practice medicine independently, right? The navigator role, though, we're really starting to talk a lot about this with the medical group and the hospital together, is what does that look like? So we have a whole team that understands how we're taking care of you in the hospital. Then we have a whole team that focuses on running clinics. And there's really no one in between. We do it in oncology. Oncology has nurse navigators because we've realized that that's a vulnerable population. There's no room for error. And so you will be connected with it's called a nurse navigator who will literally guide you, like your mammogram situation, every stage of care. Make sure you got your appointments, make sure we're getting all this done. If you have any barriers, you call me. They lead you through it. And so we're starting to talk about why can't we do that for other service lines? So for example, for cardiology, why can't we have someone who has a lens into the ambulatory footprint, the hospital footprint? And so imagine you get into cardiology and they go, hey, we're going to do this thing called a stress test. Like, okay. And then you get a positive result. Uh-oh. You now need to get scheduled for a diagnostic cath, right? There's all these steps. Those first steps to get identified that you have a positive stress test are all happening on the ambulatory network. Then they say, you need to go get a diagnostic cath. The hospital just got involved. Now you're going to the hospital. Who's helping ensure that we are seeing everybody with a positive stress test. We're understanding who's more sick than whom, like a triage system, and making sure that we're transitioning them timely and appropriately. We don't have that right now, and that's the conversation we're having, which is, could that be a navigator?
So you asked the question, why can't we do this? So my question for you is, why can't we do this? What's standing in the way of doing what you're suggesting?
We are doing it. We're heading that direction. I don't think that those conversations have been happening before, and to be candid,
Yeah.
it's not a Providence thing. It's not a Humboldt thing. I think that's another good discussion is go to Los Angeles, go to San Francisco, go wherever you want and access healthcare. It's the same. The difference there, though, is, let's say I move back to where I grew up in the Bay Area. I have John Muir, I have Dignity, I have Sutter, I have Kaiser. I have a lot of other health systems, like Starbucks, basically, on every single block. UCSF is in my backyard. I can get to anyone I want to. So if one person isn't able to give me the care that I'm looking for or to meet me where I need to be met, I will find someone else to pick that up. What we're struggling with a little bit here, I think, in Humboldt County is Providence. We really are the largest player right now for healthcare. And so we're trying to kind of get focused on how do we cement our position in terms of what matters most to our community. And one of the things my team and I have been doing for the last few years is really looking at that data and asking ourselves, what's the greatest need? What do we see the greatest need being in the next 5 to 6 years? And we need to focus all of our resources there first to make sure that we're well positioned for that. So cardiology, oncology, women's health, our trauma services for emergency care, and making sure that we have a robust integrated ambulatory network that is communicating with the hospital. The other stuff, I don't want to dismiss it. It's extremely important, but it's not my primary focus. So do I need more allergists? Do I need more dermatologists? Yeah, 100%. I can't tackle them all at the same time.
So what are the top three things that you need?
In terms of service line or just need?
Need, period. Let's talk about that, because at some point I'm going to branch off to let's zoom out to the national stage in healthcare.
Top 3 things I need. I need more capital investment, and I know that sounds kind of silly and funny. We need to invest into our infrastructure. We have beautiful hospitals. They're very clean. They're very pretty, but they lack diagnostic tools. A lot of the tools we have are old. There's some services where we do advanced things. We've introduced a lot of new things, but I have an MRI that's 25 years old, and sometimes patients have to leave the area, 3 hours or something like that, just to get an MRI, so that they can come back and do a procedure that we're able to offer them here. So they get the procedure done here, but they left for 3 hours just to get an MRI scan. That stuff keeps me up at night, and that's something that we're working on with Providence, because all healthcare is dealing with it. And what no one really talks about is we have a lot of other costs that no one helps us with. So in California, we have a seismic mandate.
Oh, of course we do.
For Providence
know.
alone.
Which I think we deeply
know.
understand what that means. Yeah.
Do you guys face the seismic
Oh
mandate
my
too in the education
gosh,
system?
yes.
Oh, I didn't know that.
Significantly, yes.
Okay.
Our whole campus is moving down the hill
Because
of
of-
seismic activity.
Okay.
Possibility, very
the
low
law.
possibility of, yeah.
So that's a $9 billion, I think it's $9 billion is the number I heard. For Providence alone,
Yeah.
$9 billion. No one's funding it. No one's supporting it.
We do get funding from the state.
We
so,
don't.
Yeah.
It's just that you better do it. No one talks about that. For St. Joseph alone, right, we're currently working on that right now. It's like $50 million plus just to
Yeah.
meet the 2025 requirements. Then we got to meet a 2030 requirement.
Yep.
And no one talks about that. So that would be really helpful, is if the state, and again, I'm not trying to say the state's not a good partner, not trying to do good things, and the intentions are probably positive, but work with us and help us figure out how we can fund that, because I think COVID proved to many of us that healthcare is actually a lot more vulnerable than we may realize. People talk about it
Agreed.
like, oh, you make billions of dollars. Well, look at how many hospitals are closing their doors, are closing down service lines because they can't continue to afford doing them.
Especially rural hospitals.
It's hard. So that would probably be the biggest thing, is some help with that. And then just the physician landscape. I really would love for this community to really come together and not say, Providence, you need to hire more physicians. Your healthcare is the worst. This is something we need to own as a community. I could go into the legacy and the sisters and the founding, and this is a special place for us. And we care about this community, and we are trying. It's a hard lift. It's a lot of work, and we've done a lot of good things. But this community can help us. I talk again about the hotels. I talk about the way we present ourselves. How do we become an environment that when someone comes out here, they want to be here, that they realize how beautiful this place is?
So it's just not the beauty of the place, though, right? So you want the community to partner with you.
Yeah.
What else in your mind should we be partnering with Providence? How can all the partners, not just the community, but education, how can we partner with you?
I think some of the work we're doing now.
Good?
Well, some of the work we're doing now, launching new programs, right? We're looking to partner with the College of the Redwoods right now to launch the Nurse Navigator program. You have the Psych Tech program,
Surge Tech,
Rad Tech.
respiratory, radiology.
all the above.
Those are huge programs. They're going to be able to support the hospitals in areas that the nursing program has shown. We've almost filled every single nursing position over the last 2 years. And that is due to the relationship we have with the nursing program. Yeah. So now we can do this. The other part of that no one talks about is county economics. How do we invest economically and grow this place economically? And I understand it's a balance. I'm new. I'm not trying to say turn this into San Francisco Bay Area. There's something we like about how rural it is here and how you can still enjoy it, right? But if you look at the population growth, we are projected to see growth the 55 and plus. But if you look at us from 35 and right in that middle range, we're shrinking. And I don't think it's because people want to leave. I think they're leaving because they don't know how to stay. So how do we do that?
That's a very good point. They don't know how to stay is important. When we talk about the future of healthcare in this region and how to solve that problem, people don't think about the economics part. All they think about is, well, we need more doctors. But that's really not the answer. It's how do we solve the economic foundation of the region to be able to support rural healthcare?
Yeah, and then you create an environment that these doctors are going to walk into and go, this place is great.
Yeah.
And I know there's people use Bend, Oregon as an example. I don't know if that's a good benchmark, to be honest, but there are communities who have done it. And I think Humboldt is very well positioned to do it as well.
So we have a lot of benefits through CR that are telehealth. Mm-hmm. Do you embrace the telehealth?
Very much so.
Yeah. I mean, I've found that for me, if it's not a serious issue, it's so easy. I mean, it takes about 15 minutes and I have an appointment and I have, a prescription at Costco an hour later. So that's been wonderful for me. And I'm just wondering what Providence...
Who do you do telehealth with? And I'll tell you ours. I'm just curious. Who do you do it through?
Well, I do MIDI for women's health, and we have Teledoc, and we have another one too. But the Teledoc and MIDI are the ones that I've been using. Yes.
And
There's
I
another.
think timely.
That's for mental health. Is timely care.
Timely care for mental health.
Mm-hmm.
There's another one called TIA. It's also women's focused. It's pretty cool. So we do a few. So we actually offer, for one, we offer services to our physicians like that as well. We offer services like that to our caregivers, especially around mental health. All of that's free and provided to them. So telehealth, we use it in different ways. We use it in the hospital setting. So for example, we have neurocritical care. When I worked at John Muir, there's a team that I worked with there who are neurocritical care specialists so all they do is neurotrauma.
So what would
stroke.
that be? Stroke. Okay, stroke.
So if you go into the hospital right now, every bedside, we have a teledoc function where those neurocritical care specialists are beaming in and they're looking at strokes, any neurological deficit. And that's been a huge impact. So in 2023, I think 24 to 25, trying to think of my timeline that I've been here, we were able to keep 100 more stroke patients in our community. And that is not because the number changed, the number of people getting strokes. It's because we didn't have to ship them out because we had a team of specialists that could actually assess it.
That. I see.
And they did that through a telefunction. We do the same thing for Redwood Memorial, for example. We're trying to really build up Redwood Memorial. I think people need to see that place has a lot of opportunity and a lot of growth, and it serves the southern county of Humboldt and actually towards Mendocino. It's not just Humboldt again. And so it hasn't happened yet, but we're going to be deploying telecardiology, telenephrology, so that's kidneys. Because a lot of times what happens, and this goes back to the access issue, you're a patient at Redwood, and to be honest, you're fine at Redwood, but you might have a little bit of a cardiac thing going on. And so the hospitalist at Redwood can't consult with a cardiologist, so they're going to transfer you to St. Joseph, even though it's just that one thing, if they could just talk to a cardiologist. So we're looking to say, hey, how do we deploy telecardiology? How do we look to deploy telenephrology? Because there's not enough demand to have a full-time person there, but to at least be able to consult and to help the physicians on staff there.
And this goes back to the imaging problem then that you have if you don't have the right imaging technology, right? Because you would need to send accurate imaging to any telehealth doctor to look at and
which
diagnose.
They all are connected through our EMRs. The other way we use tele is we use it in our clinics. We have tele options in our clinics for patients, so you don't always have to go in. And then we also offer what's called a virtual urgent care. I should have brought it. I can send it to you guys. We actually created a business card, and it has a QR code to make it easy. And it's from like 7 a.m. till 8 p.m. I've used it for like my kiddo. He's got a weird rash or something like that. And it's exactly that. Virtual doctor comes on, show me what's going on. Great. Here's your script. Is it at Green's Pharmacy? Wonderful. Off it goes. So we do offer those.
So it's a real doctor, but they're just there virtually, not a virtual doctor like AI.
Yeah, I'm doing it on my phone.
Okay.
Talking. We use a lot of AI too for tools, but not for that.
But those doctors are Providence doctors? Or,
Yeah.
Okay.
Oh, I see.
Yeah, so the strength of
Okay.
Providence is we are a large health system, and I think that's part of why I get a little flustered when people say, "Oh, rural care here is horrible." I'm like, actually, it's pretty amazing. We do neurosurgery, trauma, like the stroke care, like it's NICU, and it's because we have the resources of being a part of this very large health system that we can do this. Some of our cardiology services that come up tele are actually cardiology physicians that are based in Santa Rosa. We have endocrinology. If you need to go see an endocrinologist, maybe there's not enough patient population up here that we can have a full-time endocrinologist who lives here, but there is in Santa Rosa, and then they can do the tele visits with those patients up here. So we lean into that.
So it sounds like it's a dual problem. One, you have what you've just talked about is you have a supply problem for doctors and other services. But it also sounds like we have a narrative problem. Is that we don't know how to speak well about ourselves and say, we're actually not that bad, and here are the reasons.
Yeah, and part of that, I wonder if it's because it's been over so many years that maybe, COVID, and there was a huge exodus in healthcare during COVID, massive exodus across the country. And if you talk to people about the physician shortages and everything that's coming, I would say that we probably felt that more here. I wasn't here, but my guess would be you felt it more here than I felt it where I was before, right? Because as I mentioned, we have very good quality care. I have a subspecialist. I have a gentleman, for example, who does robotic thoracic surgery. I have a vascular surgeon, but there's like one or two.
Oh, I see what you're saying. And so if you lose one, then you lose.
Very detrimental.
Got you.
And now we're back on the recruitment thing. So let's take vascular. Okay, I have two people in this community that can do vascular surgery, Dr. Michael Palmer and Dr. Hui Tru. Great. If one of them right now says, I got to go, how many thousands of lives was that person taking care of? Knowing that recruitment could take 6 months, a year.
Or more.
Right?
Yeah.
Okay, but you can't recruit while they're here because if someone comes and they go, okay, I'm a vascular specialist, they go, okay, well, you're not going to be very busy.
Because you already have that.
I have enough for
So
two
the
full-time.
gap, yeah.
Okay.
How do I do that? And that's the challenge.
So we usually start with this, but I've been curious now, like where did you come from and how long have you been here? And tell us a little bit about your background. And
Very magical place. I was born in the Bay Area. That's my home. I will always be my home. Although this is the second largest bay in California, I found out. And this reminds me of home when I was a child.
Is that right?
Very much so. If you think of the Bay Area back in the 80s, Eureka's Oakland. It's got that Oakland artsy vibe, very free-spirited. You're on the water, right? Arcata is my Berkeley. I don't know if Fortuna is, but I like Fortuna because no one judges me in Fortuna. I don't know what that is in the Bay. But anyway, so that's my home. And then I was going to go into medicine, and I decided not to, and then I studied business instead. And so I did my undergrad at UC Davis, so I spent some time up there, and then I did my graduate at USC in Los Angeles. So I'm a fellow Trojan for anyone out there throwing a V at me right now. And I've tried to experience as much as I could. So I've worked at Sutter Health, I've worked at Scripps, John Muir, Stanford, Tenet. I did for-profit for a while, which was actually very educational.
That's interesting.
It was really educational to understand how to really look at the business of healthcare. The for-profits really have that dialed in. They're very good stewards of their resources. There's one more in there. Oh, and Kaiser. I was at Kaiser for a little while as well.
You're at Kaiser.
Yeah, and that was really interesting because that's what taught me. That's the other thing I talk about, right? So remember, the hospitals don't employ physicians. I find in a lot of places the ambulatory network in the acute setting, the hospital setting, they have no idea what the other one does. They really don't. They think that one's more important than the other, and they don't understand the interdependency.
And by ambulatory, you mean when you're walking
The
into
outpatient
an,
office.
yes.
Outpatient office.
You're
Okay,
walking
gotcha.
into an
Okay.
office and you have an ailment and
Exactly.
Yeah,
Okay.
You're not going for
Yeah.
urgent care or emergency care.
Yeah. Kaiser, they get it because that's their model, right? Kaiser's a gym membership. They want you to pay the insurance and never go into the hospital. So they're very, very good at that ambulatory outpatient work. And I learned a lot from them. I learned a lot on the interdependency of an outpatient care environment in a hospital and how they really should work together. And that's kind of what we're doing here. The difference, though, is imagine having a network that is fully integrated, communicating, coordinating your care, but you still have a choice. That's the one shortcoming I have found with Kaiser is it is hard for you to dictate your care. You may not agree with what's being told to you. You may not appreciate your physician and talk to another physician. You don't have that choice a lot of times in the Kaiser model. But imagine if you did. That would be really cool. You go, okay, I appreciate your opinion. I'd like to go see another neurologist. Great. You can. We'll get that coordinated for you. And all of it's being communicated with your primary care. That'd be amazing.
So how does Kaiser get around the not being able to employ the doctors, the ambulatory doctors?
So I'm gonna be careful here,
Yeah,
but
be careful on this one, Michael.
Kaiser is actually 3 different entities. They're the trifecta. They're an insurance product, they're a Permanente medical group, and then they're the hospitals.
Okay.
The relationship there is that triangle of how they all integrate, and they're all under the one umbrella parent company. That's how they're doing it.
I'm going to zoom out a little.
Okay.
Lots of conversation about healthcare on the national level.
Yeah.
So let's say, Michael, that RFK resigns and Trump calls you to say, hey, I need a new Secretary of Health and Human Services.
Okay.
And he says, okay, Michael, solve the problems of national health care. What is your answer? How do we do that? And really, what do people...
It's a real softball question.
Yeah.
Well,
So just so we're clear, I'm going to get a phone call from Donald Trump. That's cool. I'll record that one.
It's because I don't know if people understand where the real problems with national health care. Like, where should we be as an industrial nation that we are? What is important to us in your mind?
Okay, so I'm going to answer this. This is my opinion only. This is not a reflection of Providence. I don't know if they agree or disagree, but I'm just going to say my opinion.
Absolutely.
So I'm not opposed to universal care. I'll just say that right out the gate. I'm not at all.
Okay.
And I'm going to use an analogy as an airline, and some people are going to hate me for this. But here's
Oh,
the
I
deal.
can't wait to hear it now.
So I think everyone deserves the right to be able to get on the plane and to get safely to the next destination. Everyone deserves the right to access care, period. I do trouble it a little bit when we talk about is that Medicare, Medicaid, because I'll tell you right now, those do not cover the costs of healthcare delivery in this country, which again, people travel from foreign countries to get into the access that we have. So again, Medicare and Medicaid is a problem that we would need to talk about. How do we actually make sure that these hospitals and this healthcare environment is actually solvent? And there's other variables to there. Device, equipment, technology, pharmaceuticals, insurance. There's a lot of drivers between that are around healthcare cost. But back to the plane. Everyone should get on. That's called economy. You might be in a patient room where you might have maybe 3, maybe 4 partners with you in that room, but you're getting the same doctor, You're getting the same diagnostic equipment, the same surgical abilities. It's the same. It's high quality care. Now, let's say there's people out there that have the means and they want to be able to pay a premium. So now you're going on to Economy Plus or Business or First Class. You're all still getting to the same destination. You're all still getting there safely. You might have a private room, and it might be a nice little room with Netflix and it's streaming and all those beautiful things to make you feel comfortable on your...
Sounds fun.
Right?
Okay, got it.
Here's the care part. At the end of the day, you're both the person in the room with 4 people. And I'm not saying for sure 4. I'm just throwing it out there to kind of...
I got you. It's just an
You're an
example.
economy.
No one in our hospital is sitting with 4 people, just to be clear. But imagine the person in the room with 3 other bunkmates and the person in the private room getting a glass of champagne or whatever. Same doctors, same care, same surgeon. Everything's the same. The only difference is the amenities, the comfort. So why can't we as a country go, look, you all deserve access. You should have access to primary care. Let's be real, outpatient care, that's not the most expensive thing. You should be able to see your primary care provider. You should be able to see your specialist. You should be able to get all that taken care of. If you get into a hospital, though, now we got to talk about that. Are you under the economy where you just get the government plan that's provided to you and you're good with that? Or no, I want something a little more special. I want more comfort. Great. Then you pay for that. That's where I think we have the imbalance. The way the system works right now, and it's been referred to as the hidden tax. So people say, well, I'm not going to pay for someone else's healthcare. But you do. And the way that happens is to cover the costs that we lose for Medicare and for Medicaid, we go to Blue Shield, we go to United, you name a commercial insurance plan. Ask yourself why your premiums at
Keep
times
going up.
They spike sometimes.
Yes.
They're spiking because we're having to go back to the table and negotiate. I would also say you need to ask yourself, why do you, when you walk into a hospital, and I have a nice hospital, and I've experienced some that are much nicer. Walk into a hospital that has a piano, grand piano, it's beautiful, kind of whatever aquarium type of tank with bamboo in it. And ask yourself, how does that help you get better and get healthier? I don't know if it does, but it's beautiful. It's also extremely expensive. And so just know that when we're going to the insurance companies, we need to negotiate those rates. And that's where the commercial part is kind of that hidden tax, right? So it's going up. You're also paying for, and this is why preventative medicine is so critical. If you go to St. Joseph, and let's say you just go in because you have a cough, and you leave the ER, and you have the best experience, everything's great, 10 minutes or less, you saw a physician, you go home. You're going to get that bill, and you're going to be very upset because you got that bill. But you have to understand that you went to a hospital that I am paying for trauma surgeons, neurosurgeons. These people are on call 24/7, 365 because that hospital is meant to be there to save lives. So how do we create a robust ambulatory network that helps you live a healthier life? So if you're going to the hospital, you're going to the hospital because you really need to be there.
I just heard a story about someone who had very good insurance through their work, but they had twins who had to be in the NICU, both of them. And the bill that she saw that she didn't have to pay was over $1 million. So how...
I'm laughing for different reasons, not because
anything-
I'll tell you why.
I'm just curious why you're laughing, but okay, go ahead. with
I
that
mean, why? That was outrageous to me, and no one can afford that. And I understand the costs that hospitals have to employ all of the specialists and that people are traveling here to get the best care. But that still seems outrageous to me.
She didn't pay that, just to be clear, right?
No, the insurance paid it.
Yeah. So I'll clarify that for you too.
Okay.
Welcome to the complexity again. So you go,
Right.
how do I fix it? This
do you
is why
fix
there
it?
needs to be a baseline. So it's different. Every contract negotiation is different. And I'm not the expert in this, but from a high level, this is how it works with commercial insurers. They pay you based on a percentage of your gross charge.
Explain that one for us.
So let's say I say, hey, this costs $100. They go and they say, we're going to pay you 25% of gross charges. You're capped at blah. That means that for every $100 that actually something cost, they're only going to give me $25. So guess what I got to do to make up my cost?
Jack up the price.
4 times.
Right.
That's why when the government is trying to do this price transparency, again, very well intended, not the right model. Because if I just show you what my gross charges are, and to be completely frank, they're almost meaningless. Because if you look at gross charges across hospitals all over, they're all over the place. Why? Because the way they contract with private insurance is all over the place. It's different by every hospital, every health system, right? Some are, we pay you a daily rate, some are a percentage of gross charges. You don't know. So to try to look at price transparency or get your bill and go, this was $1 million, probably not. They probably just had to gross up the charges to actually get reimbursed what they needed. And then on top of that, I need to make some margin, some sort of profit to make up for the losses for Medicare, Medicaid, uninsured. That's what that comes into.
So it's padding the cost a little bit.
Yeah,
Okay.
and it's hard because it varies across. And again, even depending on the commercial insurance, the negotiation and how they reimburse is different. There is no standard to how that's done. So Anthem, Blue Shield, United,
This is
it's
why
all
people
different.
argue for the single payer, because it makes everything
simple.
more transparent
It's
as well,
simpler.
too.
Even from a physician's perspective, if you went to a primary care and you said, hey, because they're on the phone a lot with insurance, right? They're getting a denial. They're like, why are you denying this? And it's exhausting. It's actually a big cause of burnout. But if you ask them about how's Medicare, again, Medicare doesn't pay well, but at least you know what you're going to get. You know what's authorized. You know what's not authorized. There's no back and forth. It's simple and it's easy. That eases their way. I don't think that's still the solution, though, because there's a lot of other problems with Medicare.
I mean, I'm still wondering if it would really realistically cost $250,000 for those two babies, where it could. I mean, it's just another problem with how expensive things are.
Yeah, to give you guys perspective, it can cost a hospital $1 million a year just to have general surgeons on call. Some hospitals pay
How
upwards
much?
to $2 million, $1 to $2 million a year just to have a surgeon
On call.
on call, and that's one specialty. So imagine you're doing, and then there's different specialties, different risks. Imagine neurosurgery, imagine trauma. Neonatal NICU is actually probably one of the higher areas in a hospital. It's a beautiful area, but it's the most vulnerable, high-risk population. The other aspect, as I digress, is malpractice. Ask yourself, why do physicians feel like they need to be paid the way they're paid or protected the way they're paid?
Because malpractice insurance.
Ask how much they pay for malpractice. It's crazy because they feel they have to be protected.
So the insurance companies, again, are
Different,
Different,
but it's like the insurance we have with our cars and stuff, right? My premiums, I don't know why they keep going up.
So it seems like with the real cost of healthcare, like the legitimate real cost that it costs you to employ surgeons and doctors, and that the government is the only real entity that has the money to pay.
Well, we get it.
Except through insurance companies.
Yeah, but it costs us millions to run these hospitals. Just to give you guys perspective, it's double-digit millions.
Sure.
When I pay out caregivers, physicians, the technology, the equipment, it's a lot. And it's expensive.
And it's a public good, and it's something that, it seems like should be covered by the government.
At least the baseline, right? Like you shouldn't have
right.
to worry
The economy,
about getting in.
yes.
Yeah.
You know, Michael, as you were speaking, I was thinking about your position as a CEO. And as you were speaking, I'm more concerned about you than ever.
Thank you.
Because I think that you're
Am I
very, very
getting wrinkles on
good. But I'm beginning to understand the complexity of your job. I thought my job was complicated, but your job is horrendously more complicated.
Thank you.
So how do you get through the day knowing that everyone's coming after you, that you can do no good,
Yeah.
but you do everything wrong, and you're trying your best to stay up and to take care of people?
Is this what you've heard?
No, it's because no, actually, I understand. But
Yeah.
so how do you get through the day? What is your day like? How do you maintain focus and balance?
Okay, a lot to unpack there. So let me start with I love what I do. And there's a lot of good we do. Yes, it's hard. I don't know how to explain it. To recharge my cup is actually the day I get out of the office and I round in the hospital. Sometimes I sit in the lobby and I just talk to people. Sometimes I sit in a patient room and I just talk to someone. There's been times where I've had full-on conversations with a guy, not even realizing this person's like homeless. I've had substance abuse users, but they're human beings. And when you hear someone communicate to you how thankful they are, or just how well they're doing, there's something about that that just completely refuels your cup, and you go, "This is worth it." The part that gets hard, you're right, is the other side of the job, which is like what we're talking about now. Your other question was, how do I get through my day? So that's part of it. I'm also very structured. Something I've learned in my role is I don't have room for ambiguity. I get up at 5 in the morning every day. I shower. I have the same start of my day. Like I have a banana shake, coffee.
God, you sound really boring to me. So okay,
Right?
go ahead.
Yeah. I go to work. I get home. I
Yeah.
usually get home around 6, 7 p.m. And then I work out for about 30 to 45 minutes. I sit down. I have family. I have dinner with my family. I put my boy to sleep. And then I'm back on. That's my everyday.
Okay. So I see your point. Yeah.
But I need that
see your
structure to stay on top of things. I do hit walls. I think we've all hit those. Like we all hit those moments where you just feel like you don't have anything else to give. But again, then I interact with our caregivers. And I think like you, we talked about this. It's there is a responsibility in the role that it is hard not to feel motivated. So like we employ about 2,000 caregivers in this community, okay? Every one of those people has a mortgage. They may have kids who are going to college. Like that is a responsibility that I don't know if people realize it, but I think about that all the time is
yes.
how do I make sure that I continue to take care of these people, employ these people?
Yeah, we think about that all the time.
Yeah. When I was at Scripps Health, the CEO, his name's Chris Van Gorder, he was my mentor. And he really made that point is that if you hire somebody, you just become responsible for their entire life. Mm-hmm. So be very thoughtful. Anytime you just create a position or you hire, whatever you're doing, be thoughtful because that's your responsibility. I've always taken that to heart.
It charges you, doesn't it?
Yes.
It works the same way with me.
I love it.
Yeah, same way with me. Thank you.
So we've talked a little bit about our partnerships that we hope to have with you in the future with our healthcare.
No hope, we will.
Yes, we will. Our new healthcare programs and the continuation of the nursing program. But what are some other things that you want people to know about where Providence Humboldt is going and what we can look forward to?
I get to do a plug.
Yes.
Yeah. All right. Thank you for that. Well, I'll share with you guys kind of where my vision is for this when I look at this community. So one more thing I think people need to understand is we serve not just Humboldt County, we serve 5 counties and even Oregon. I get about 100 transfers a year just from the Oregon territory alone up to about Brookings. So to give you guys perspective, like that's who we're caring for.
I didn't know it was that large of a region, actually.
Yeah, I've heard someone once come up to me, they go, if you took Rhode Island and Delaware and put them together, we are larger than that, the geography that we serve.
I had no idea.
Yeah, I just learned that one. I was like,
Okay.
oh, that's interesting.
Wow, that's
Look at it
huge.
that way. Yeah, it's massive.
Yeah,
And so
we think we have a big service area, but you're even extended out.
it's huge.
Yeah.
And it's important to understand that because a lot of people just think Humboldt, why don't we have access? Like, well, because I'm dealing with this. This is monumental. So the vision we have is a few things. So one, St. Joseph needs to start being seen as a regional tertiary level care center. It already is, but we really need to decant that pressure. And so right now what we're looking at doing is developing, so general hospital, we're actually looking to get that completely shifted under the city jurisdiction and oversight, take it off the state. And the reason for that is it will no longer offer inpatient care. I want to take all of our outpatient centers, and we talked about care coordination. So in Eureka, we have 12 locations alone. In Eureka, 12. Yeah. And if you go to some of these offices, they're not great. And there's like maybe 2 doctors in there. Yeah. Okay. Imagine if they were all in one building. So you walk in, you have primary care. Oh, you got to see a cardiologist? Go upstairs. Oh, you need cardiopulmonary rehab? That's right next door. It's all there.
Makes the navigation much easier.
Much easier. Your doctors are
Good
talking.
point.
You know what's going on. It's all there. That's what we're starting to work on right now is how do we bring that in and build that kind of presence? The next part is we've reopened the surgery center. We've invested much more into Redwood, and I want to continue and invest in those areas. So for people that need quick procedures, fast outpatient surgery, hey, you're getting your hip replaced, we get you in and out of a day. You don't need to be in such a high level place like St. Joseph, right? You don't need all of those kind of tertiary services. So I want to create more capacity in that hospital so that when people are calling us and saying, I have someone who needs higher level of care, I can say, we can take care of you right now. We have a bed. Because what happens a lot in healthcare, and anyone that's had to deal with a transfer, you could sit in a hospital for days, hours to days, waiting for another hospital to say that they can take you. That's frustrating and that's scary. And so that's what we're trying to get to. And then eventually I want to start expanding that landscape. I want to be able to spread our wings a little bit into more of the peripheral communities. So we are starting to work a little bit with UIHS. How can we integrate with each other? How can we...
United Indian Health Services.
Thank you. No acronyms.
No acronyms, yes.
We're talking to Kamal Medical Center.
Oh, good.
And that's something like as simple as, let's say they have a patient that needs to come to our ER. And then we go, your patient's fine. We send them back to you. But maybe we didn't realize something because we weren't communicating with that physician. It's extremely difficult for that patient to have to come back. It's not as simple as, oh, can you come back? We're going to take it. No, it doesn't work that way.
It's too far away. Yeah, there's lots of distance.
So our physicians are starting to talk. And then the last part is we need to start looking at, we call them ancillary partners. So you got to think of stages of care. Okay, so there's your outpatient primary care, your cardiology, there's your hospital, but then there's what's called post-acute. You leave the hospital. Do you go home? Do you go to a skilled nursing facility? Do you go to an assisted living facility? That is something that I think we are starting to work on a little bit more in terms of how do we coordinate that care to make sure that it's seamless and that it meets the quality standards that we would expect at Providence to make sure that you have all those transitions of care.
And are you planning on building a hub?
New hospital?
No, a hub so that all of the outpatient doctors and everything are in the same area?
One central
or
So general
central
campus,
area?
the old general hospital is going to be
Okay.
that. We're actually starting this year to meet with an
That's where you're
architect.
going to put it, the old general hospital?
Yep. Once it's under the city, we're looking at completely, we're working with an architect.
Once you're
to do
what,
it
I'm sorry? When you're
within the city's jurisdiction. So Eureka will basically be giving us the oversight for any permitting, construction, et cetera.
Oh, interesting. Okay.
And so we're working with an architect this year to start kind of programming and go, okay, how many
Great.
square feet do we have to work with? What can we do? And what does that look like? So we're going to start working on that this year. The project alone, though, is going to take multi-years because it's a multi-million-dollar project. So like earlier you asked, what do you need? For those who are
Capital.
listening, I'm going to be
Capital.
leaning into this community for help. But this
Okay.
is the stuff that's going to help us and I think have better care. And it'll help with recruitment too. Imagine a physician, you're coming in and I'm like, yeah, this is our, I don't know, I'll call it outpatient center, whatever it is. Everyone's in here. It's modern. It's new. All the technologies at your fingertips. As a new physician, that's exciting.
I've enjoyed this conversation.
Thank you. I have too.
I've learned a lot. So
Thank you.
Thank you very much.
Yes, thank you very much for joining us. This has been Free Speech with CR.
And our guest today was Michael Keleman,
Thank you.
Thank you for joining us.
Appreciate it, guys.
CEO of Providence Humboldt.
Providence
See
Humboldt.
that?
There
Doesn't
we
that
go.
flow? There's flow.
It just flows well. Thank you.
Thank you.